28-year-old man has circumferential burns over his lower legs after a house fire. Following resuscitation, he developed severe bilateral lower leg pain and swelling, with firm, shiny skin and absent pedal pulses. Which is the most appropriate treatment? A. Amputation. B. Debridement and split-thickness skin graft. C. Escherotomy. D. Emergency revascularization. Or E. Fasciotomy. So I want you to pause the video here and just have about 30 seconds to think about the correct answer. And the correct answer is C. Escherotomy. And we'll go through why in the following slides. Burns describe a thermal, electrical, chemical or radiation injury to the skin. They are classified based on the depth of burn and the total body surface area affected. Classification includes superficial or first-degree burns, where the epidermal layer only is involved. Symptoms include pain, redness and warmth, but there is no blistering, and this is common with things like sunburn. Next, you have partial thickness or second-degree burns, which involve the epidermis and partial dermis. These is further broken down into superficial partial thickness, with symptoms including pain, redness, moisture, and blistering, or deep partial thickness, where there is less pain and the skin can appear white or mottled. Full thickness or third-degree burns include the burn extending through the entire dermis and are often painless due to nerve destruction and are associated with lethargy and systemic malaise and charring or a white appearance of the skin. Fourth-degree burns extend through the entire full thickness of the skin into the muscle, bone or deeper tissues and are associated with significant morbidity. And here we can see a pictorial overview of the classification of burns based on the depth of penetration through the dermal layers. So you can see that superficial burns, previously known as first degree, involve just the epidermis, and with progression through the subcutaneous tissues to the muscle with fourth degree burns. Symptoms of burns, as touched on previously, include pain, which decreases with increasing depth of burns due to destruction of nerve endings, erythema, blistering from second degree upwards, charred or leathery appearance of the skin, soft tissue swelling, and significant fluid loss which can cause dehydration and electrolyte imbalances with severe burns affecting a large area of the surface area, and systemic symptoms including shock, fever, confusion, difficulty breathing associated with inhalation injuries, and multi-organ dysfunction in severe burns. In this picture, you can see a T-scold over the chest and shoulder of a child, showing the heterogeny of burn depth. D depicts an area of deep burn where the skin appears white. I is an intermediate where you see some blistering, and S is superficial where there is erythema only. The approach to a patient with burns includes an A2 assessment and appropriate resuscitation. Clinical examination should be performed of the entire body to assess the depth and the total body surface area affected. Relevant investigations include basic bloods, including full blood count, Usenes, LFTs, and ABG to assess for lactate looking for tissue ischemia, and carbon monoxide levels. Chest X-ray or bronchoscopies are indicated in suspected inhalation injuries to assess the extent of lung parenchyma damage. Wound swabs and cultures may be appropriate if there is concern for infected appearances of burns, and close urine output and fluid status monitoring is essential, particularly in severe systemic burns. Considering classifying the total body surface area affected, the rule of nines is commonly applied, with 9% of each anterior or posterior surface of the leg, 18% for the entire trunk, 18% for the back, head and neck, posterior and anterior accounting for 9%, and the arms, hands and shoulders accounting for 18% between them. Management of burns includes stopping the burn, so removing any heat source or rinsing off burning chemicals on the skin, cooling the burn with lukewarm water, however ice should be avoided because extreme cold can damage the skin tissues further, constrict blood vessels and potentially worsen the burn by reducing blood flow and increasing the risk of infection. And the burn should be covered with clean non-adhesive dressings to reduce the risk of infection and reduce the fluid output from the burn. Medical management includes analgesia, appropriate fluid resuscitation, Antibiotic and tetanus prophylaxis and nutritional support is essential. Adequate fluid resuscitation follows the Parkland formula of 4 mL per weight in kg times total body surface area burned. Half of this should be given over the first 8 hours, and the second half should be given over the second 16 hours. This is resuscitation, and maintenance fluid should be provided alongside this. Further management of the burns includes antiseptic dressings such as silver sulfasalazine or honey-based dressings. These can also be beneficial in aiding enzymatic debridement of the burn. Escherotomy describes the procedure of incising a thick eschar that can develop in full thickness burns, and this is essential in circumferential burns, as a thick eschar development can increase the risk of compartment syndrome, and in this case escherotomy is an emergent procedure to perform. Debridement, as just mentioned, should be performed, which is either performed in the operating room or enzymatically with dressings and topical agents. And reconstruction should then take place, which is typically in the form of split-thickness skin grafting. Here in these images we can see a depiction of surgical debridement following the placement of a meshed autograft and the stages of healing of that graft. It is useful to consider where meshing may be beneficial to increase the surface area of the skin graft taken. It is associated with a less favourable aesthetic result post-operatively. However, it reduces the amount of donor skin required, and it is useful to think about how when you take a split thickness skin graft, you're effectively creating a further quote-unquote burn on the skin. So you're increasing the total body surface area affected by a burn or a similar type of wound. Hence, this can have implications for healing, fluid output and nutritional status. So meshing in this case, despite being associated with the less favourable aesthetic result, may be beneficial in terms of overall patient outcomes. Complications of burns include, in the early stages, in significant burns, hypovolemic shock, infection, acute respiratory distress syndrome and electrolyte imbalance. Late complications can include chronic pain, burn scar contractures as depicted in this image, psychological implications and long-term disability or disfigurement. Just going back to our question, we can see the key features in this stem which suggest the need for escherotomy are having suffered circumferential burns, and then following resuscitation where tissue reperfusion has taken place, the development of severe bilateral lower leg pain and swelling, firm shiny skin and absent pedal pulses, which are all red flags for compartment syndrome. Hence, escherotomy in this case is required to save the legs.